Blood filters. There are two primary types of filters used for blood filtration during CPB: depth filter and screen filters. Depth filters. Depth filters consists of packed fibers of Dacron wool or polyurethane foam. These filters have large wetted surface areas to filter the blood by absorption. They are effective in trapping gross bubbles. In depth filters, the particulate removal depends on the amount of wetted surface area, the filter thickness, tightness, and material, the chemical structure of the particles, the diameter of blood flow pathways. Screen filters. Screen filters are composed of woven mesh of polyester fibers with defined pore sizes in the mesh from 20 to 40 micron to determine its filtration ability. Virtually all of the arterial line filters used are the screen type. Most arterial line screen filters have plates to increase the surface area and permit acceptable blood pressure drop at clinical flow rates. Particulate material is trapped in these filters because the particles are larger than the pores. Gaseous microemboli are also trapped due to surface tension effects from the wetted pores. The chordatum reservoirs receives the venous blood, which contain a large amount of debris along with room air. Therefore, it contains an internal filter mechanism that relies on a combination of the depth and screen filters. Arterial line filters. Arterial line filters are the most important component of the cardiopulmonary bypass circuit to limit source of embolic load to the patient through the perfusion circuit. Arterial line filters are a screen type composed of woven mesh with a pore size larger than 20 to permit adequate blood flow without excessive blood pressure drop. Line filters removes the gaseous microemboli by surface active forces on the wetted pores. A sudden decrease in flow velocity when the blood contains the wetted mesh after entering the filter cause the air bubbles to rise the top of the filter where they can be purged from the system. White cell filters, leukocyte depleting. Leukocyte depleting technique may be included in the bypass setup by using arterial line leukocyte reduction filters to continuously filter white cells throughout the cardiopulmonary bypass period. This technique has demonstrated some clinical benefits. The new generation of leukocyte depleting filters are composed of synthetic microfiber materials prepared as non-woven mesh. These filters remove 99% of leukocytes from the blood. These filters are composed of depth or screen filter types. Hemoconcentrators, hemofilters, hemoconcentrators, ultrafilters. Blood filters are devices mainly consisting of a hollow fiber semi-permeable membrane to allow the passage of water and electrolytes from the blood to filter the chamber and waste bag. Hemoconcentrators are used during extracorporeal circulation to remove excessive fluid and electrolytes, remove inflammatory mediators generated, and raise the hematocrit. Are shown in this figure. The size of the molecules which are removed by the hemoconcentrator blood filters are depend on the pore size of the hemoconcentrator membrane. Usually molecules up to 2000 daltons are removed. Example water, electrolytes, heparin, and various inflammatory mediators. However, hemoconcentrator filter cannot remove plasma proteins and blood coagulation factors, albumin, immunoglobulin, because the plasma protein molecules mass are above 65,000 Dalton. These maintain the plasma colloid oncotic pressure. The hemoconcentrators is normally connected to the CPB circuit at the systemic flow line port to provide a driving force to pump blood through the device, where blood is filtered before returning to the patient. The speed of the fluid removal is usually 30 to 40 ml per minute and depends on hematocritic level, the membrane pore size, and the pressure in the hemoconcentrator membrane. Filters may be used during or after cardiopulmonary bypass (MUF) to manage hyperkalemia or for hemoconcentration if the hematocrit is low and circulatory volume is adequate. A small priming volume hemoconcentrator are used during neonatal heart surgery to avoid excess circuit volume. Advantage of hemoconcentration: reduction of homologous blood and blood products needed, increasing hematocrit level that improves arterial oxygen content and maintains the adequate oxygen delivered to the body, decrease post-operative bleeding as platelets and clotting factors are kept, control the intracellular water level by retaining plasma proteins and decrease tissue edema and organ dysfunction. Operative cell saver. The cell saver autotransfusion is a machine used to collect lost blood from the operative field and separate RBC from whole blood, then washes from the reinfuse them back to the patient as red blood cells. For use, patient has a rare blood group or multiple antibodies. The antiseptic blood is lost during surgical procedure is large. Patient has risk factor for bleeding. Low pre-operative hemoglobin. Patient are unwilling to receive donor blood for moral, religious, or other reasons. Like and share, subscribe. Perfusion Talks.